So welcome and thank you for joining us. Today we're going to be talking about the role of the therapist in psychedelic therapy. And I'm Elizabeth Nielson. For those of you I have not met yet, I'm so glad that you're joining us today because today's discussion should be really, really interesting and hopefully help you understand a lot more about how psychedelic clinical trials are constructed, what the role of the clinician is in those trials, and just how you might think about how that research plays out and translates into the kind of work that you may do, either in a research trial or in your clinical practice in the future. So a couple of things that I wanted to note as we're just starting today. We are here on Zoom. We've got some guests we're very excited about, authors of a recent research paper, which I brought my copy of just, so you can all see I did my homework. The paper is Must Psilocybin Always Assist Psychotherapy. I'm sure many of you have read this. It was published a couple of weeks ago, and we really appreciate that we have two of the authors of this paper online with us today. Before we get to that, just welcome to the webinar. I see a few more people joining us. So if you'd like to go ahead and introduce yourself in the chat. We do have the chat feature on for you today. It'd be really nice if you could share, your name, make sure that your name is updated so we can tell who you are, and maybe share where you're joining us from so we can see a list of all the different places. We've often got a really wide variety of folks from around at least a few different countries in the room. So say hi. Let us know where you're joining from. It's a really great, vibrant list of folks. I see some people here who've been in our certificate program, some people who are on our faculty and our staff, and we really appreciate that you're here with us. We also have the Q&A function on for this program. And so towards the end, we're going to be pulling some questions from the Q&A question feature. And so if you do have questions that you'd like us to address or things that you'd like us to talk a little bit about, please put those in the Q&A function in Zoom. If they're in the chat, we might miss them. There's often a lot of commentary or conversation, and it's just not the primary place that we're looking. So if you do have a question, please use the Q&A function in Zoom for that. All right, well, let me get started with the conversation here. So again, I'm Elizabeth Nielson. Those of you that are coming in a few moments later, warm welcome to you. I'm the co-founder of Fluence. I'm a psychologist, and I have a background in working in clinical research trials with psychedelics. And so this program is really a convergence of some of the things that I'm most interested in, which are how do we take psychedelics, which have these fascinating subjective effects, and actually do the research that helps us to get them approved through our medical healthcare approval system, so that they can come through that system and become available to folks who are struggling with their mental health. And so this is a complex process. There's a lot of steps involved. Research design is tricky. There's a lot of caveats. There's a lot of checks and balances and regulatory things that need to be thought about. But when we think about clinical trial design, it's really important that we're thinking clearly about generating the kind of evidence that we need for this approval process. And so you'll hear us talk today a little bit about clinical trial design, maybe introduce some new terminology for you so you can be helped to understand how those trials are designed and maybe why they're designed in the way that they are. In terms of my background a little bit more, this paper actually talks about, I think, 7 different research trials that they're pulling examples from in terms of the history of research of psychedelics. And I'm fortunate to have actually worked on 3 of those and seen a number of participants in each one. So really having worked on a wide variety of different types of trials and trials that were designed in different ways. So you'll hear me be speaking from that experience a little bit today. Another thing I just want to note is that, the authors of this paper are affiliated with Compass Pathways, which is one of the trials sponsors that is included in the paper. Fluence at this time is not actually working with Compass Pathways in a formal manner, although because I previously have worked on Compass Pathways trials outside of my work with Fluence, we have a good relationship. We're friends. We say hi, we keep in touch, and that's why we are having this conversation here today. But we're not a formally in partnership with Compass Pathways at this time. We do have partnerships with multiple drug developers, though, and many of those drug developers are putting psychedelic therapies, psychedelic treatments through this process of trial design and, with the intention of going for regulatory approval. So this is a part of the field of psychedelic research that we're very, very involved in. The primary thing that we do is design training programs and train therapists, or sometimes they're called monitors or facilitators, depending on the trial, in delivering the treatment across multiple sites and multiple jurisdictions, all in a way that is aligned with the regulatory needs of the clinical trials environment. So that's a little bit of the sort of framing and background in terms of where we're coming from today. Again, we're very excited to have the authors of this paper joining us for this program. I'm going to pause for a moment, and I'm going to invite my Fluence co-founder, Ingmar Gorman, to introduce himself. And then we're going to go to hearing from Don and Guy from Compass and the authors of the paper that we're discussing here today. Ingmar?
Thank you, Elizabeth. I'll keep this short. So you all probably know me. I'm a co-founder of Fluence with Elizabeth, a psychologist, a clinical psychologist by training, and have also shared experiences both on the Compass trial, very briefly, certainly not to the extent that Elizabeth was in the past, and also on the Lycos, formerly known as MAPS trials. So very eager to hear this presentation and also the discussion, because as we know, we try to learn from what is happening in the clinical trials, contribute to clinical trials, as well as hopefully translate those learnings into its application, the potential application of psychedelic medicine in the future. So again, I'll keep it short. Really looking forward to the conversation. Thank you.
How about if we go to Don?
Yeah, thank you both. I appreciate you guys hosting this webinar. It's really a great opportunity to come and talk to everybody. I'm Don Koelpin. I'm a clinical psychologist and currently the director of training for Compass. I've been with Compass for about 2 years, and my role there has been sort of twofold. One of them is to kind of oversee the training of therapists and the development of the training materials, and then also taking the lessons learned from our phase 2b studies and other trials and making sure that those are incorporated into the support model and how it's delivered and how we think about it as a form of support for the work that we're doing. I think a little bit of professional background. I spent many, many years working with veterans in the VA hospital, doing a lot of acceptance commitment therapy and mindfulness-based work, and also ran some training programs there. And then also, just to clarify that I technically am not an author on the paper, even though I've been working on the projects, just for transparency.
So my name is Guy Goodwin. I'm Chief Medical Officer at Compass Pathways. I'm a psychiatrist. My background really is largely academic rather than in industry. And my interest has long been in the treatment of mood disorders. And I was head of a department of psychiatry in Oxford, where cognitive behavior therapy was a very big part of what we did. So I like to think of myself as having my foot in both camps as far as drug and psychotherapy goes. But you'll see, the way in which we've thought about it in relation to psychedelics is maybe a little bit different. Don and I are both employees of Compass Pathways, and both of us may be making what are sometimes called forward-looking statements, predictions about what will happen. I think to understand the probability of things panning out, you need to look at our risks, which are registered in statements that we make to the SEC in New York, and which you can access online. So where do we start? I think it would be useful to remember that Compass published in 2022 the largest of the controlled trials of psilocybin, COMP360, in treatment-resistant depression. And I was involved from the beginning in developing that study and thinking about how we would deliver the psychological support that we always assumed would be necessary to deliver it safely. Now, the Compass Pathway Support Model, which we'll sometimes clumsily call the CPSM, was therefore developed in 2017. So it's already 7 years ago. And it was part of this development program that Katya Malievskaya, who unfortunately can't be with us today because she's in the desert, was the key individual who put together this program. And it was really based on selecting evidence-based psychotherapy practice to look at the historic use of psilocybin in research and clinical and frankly often underground settings, but with the advantage that we could talk to Bill Richards, who was one of the people who was old enough to have actually practiced legally when it was still available for use, particularly for patients with cancer, and had advised the Hopkins group as well. And of course, the Hopkins group's experience and our current understanding of how psilocybin actually works, which is, as you probably know, probably through a single or several receptors for serotonin in the brain. So that was the initial approach, and there were further adaptations, which Don will talk about, which were based on our phase 2b clinical trial and other investigator-initiated studies, because those are other important pieces of experience that we've got from a range of excellent investigators across the world, actually, but particularly North America. And finally, we've had key dialogue with regulators in the US, in the EU, and the UK, and they have shaped how we have designed the clinical trials, both that we've completed and that are ongoing. So I'm afraid I'm going to be somewhat didactic and put on some slides. And the reason for that is just simply that I want to be clear that we're all on the same page in understanding the constraints that are put on us by the use of, by the demands of clinical trials. And just to get everyone up to speed on what I mean when I talk about clinical trials. So why and how do we do them? The reason we do them is that if we go back in the past, and this is the very distant past, but it's in fact, unfortunately, a problem for human beings still, that all who drink of this remedy recover in a short time, except those whom it does not help, who all die. Therefore, key human logic here, it is obvious that it fails only in incurable cases. And that logic is very human logic, and it was actually the basis for the way in which most doctors thought about how to treat patients until remarkably recently. And the whole methodology of clinical trials is designed to overcome the human tendency for confirmation bias and for inventing explanations that cannot be borne out when you subject them to scientific scrutiny. So this is why we need to do clinical trials, that kind of human malfunction, if you like. Now, the requirements that the FDA started making these advanced requirements for drug efficacy and safety in the wake of scandals, particularly the thalidomide scandal in the 1960s. They require that anyone developing a new drug should show evidence of efficacy. Does the drug work? And secondly, evidence of safety. Now, evidence of efficacy has to be based on what they describe as an adequate and well-controlled trial. And that really means that you make a valid comparison between your treatment of interest and a control treatment. It isn't specified further than that. You have to decide how you're going to do it. In addition, you have to take adequate measures to minimize bias, the kind of bias that leads you to the sort of conclusion that Galen was inviting us to make. And thirdly, that in assessing the subject's responses, you use well-defined and reliable outcome measures. And obviously in psychiatry, they are usually subjective reports, and that means there's a particular need to pay attention to bias in that regard as well. Safety is usually based on open complaints that the patient makes or measures of changes in physiology or pathology which appear to be related to the effects of the drug. Now, the characteristics of these adequate clinical trials are that, first of all, one has to define a patient population. And our initial approach has been to look at treatment-resistant depression. Those are patients who have failed at least 2 treatments with a drug. The second is you need to compare 2 or more alternative treatments. And that may be placebo, or it may be different doses of the same treatment, or it may be 2 different treatments. You may use a treatment that you don't believe works, but produces some of the subjective effects of the drug that you think that will work. These treatments should be compared by randomized and blinded allocation of treatment. In other words, it shouldn't be possible for the person delivering the treatment to influence who gets what treatment. And that's very important to the principles of this. It's a fair comparison. People are randomized. And this, I can tell you, is very much against the human spirit. That's what makes randomized clinical trials quite difficult to do. And not everyone can actually do it. They just want to give people the best treatment, whatever, on the basis of what they believe. Final thing is that there should be blinding, preferably that the patient should not know what they're receiving, and that in people observing the patient should not know what the patient had received. And so this blinding receives a great deal of emphasis. And it's a particular challenge, as you'll see, for our sorts of studies. But with most drugs, there are simple measures to go for blinding. First of all, you will have identical appearance and number of pills. The blinding will often depend on whether these pills produce subjective effects, often adverse effects. You know, it might be feeling a bit nauseous, feeling funny taste in the mouth, getting a bit of tummy disturbance, anything like that that cues the patient that they've had the active drug could be potentially unblinding. Now, clearly, you can ask patients after you've treated them which treatment they think they've had, but we know that when you do that, those guesses are quite influenced by what actually happened in terms of the outcome. So although people talk about measuring blinding, it's not actually as easy as you might think. There are problems with doing it, but it's in the ideal case, you would want to see complete blinding. In addition, it may be less important if expectations are low or if the patients are indifferent to treatment choice. And I hope as you go along, you're noticing some of the particular challenges that result from these requirements for the studies that we're doing with very psychoactive drugs, where people may come in with very strong opinions about whether or not they're going to work. So you can see that in preparing patients for trials, you're going to have to think about this as you prepare them. And finally, as unblinding may lead to biased reporting. So, you know, people may be very invested in their treatment. This is a problem for psychotherapy trials, that you have what is sometimes called allegiance bias, and that can lead to positives that are essentially a little exaggerated. So blinded treatment are an issue for drugs. For psychotherapy, as you're probably aware, if you do psychotherapy trials, the treatment and the control the treatment should look the same. You should have the same therapist enthusiasm, the same attentional demand for the patients, the same sort of timing, and preferably a different mechanistic approach, which allows you to say that something like, say, CBT is different from maybe relaxation training. You know, that's the kind of the sort of trial I'm thinking about. Blinding is, in a sense, difficult because it requires patient cooperation. And often the only real way to do that is with a certain amount of deception. And there are some great examples of where the dummy treatment has been kind of made to seem as if it's likely to be effective. And the trials, for example, of the CBT for sleep disorder, insomnia, have been very nicely controlled by inventing a treatment that has none of the elements of CBT, but is sort of plausible as a treatment for depression, and pardon me, for insomnia. So that's a very good example of this approach. If you ask about blinding, you'll induce guesses, again, that will be influenced by the outcome. And I think it's true that psychotherapy may be particularly vulnerable to placebo effects, by which I mean placebo as in the sense of pleasing, wanting to please the therapist, wanting to make the therapist feel good. Our patients are very good like that. They tend to score us very highly for our efforts, even though they're not necessarily doing great. So the challenge of clinical trials with serotonergic agonists are that the drug effects tend to be and will be often unblinding. It's very different to have a placebo control. And for that reason, we've always preferred, although we have to do in one of our studies placebo, we have preferred to use different doses. The patients coming into these studies need to have a preparation which needs to be standardized. So the preparation for the patient needs to be highly standardized. It needs to exhibit equipoise. Now, what I mean by that is that what needs to be communicated by the person, the facilitator, the therapist, is there are equal chances of response, that you're not certain to get better when you get the active treatment. You may very well get better if you get the control treatment. And that idea is sometimes a little difficult to sustain if you've read Michael Pollan's book and you think that you're going to get a miracle cure for the disorder that's plagued you for a long time. So I think it's a particular challenge for our therapists to try and communicate equipoise, to point to the results and say, actually, unfortunately, not everyone gets better. The differences between the different doses is not as great as we would like it to be. And so we need to be realistic about our expectations. In fact, many patients with depression actually come into our studies very, if you like, they're not really convinced that they are going to get better. I think there may be some cultural differences. I come from the UK where everything seems, the future always seems bleak, whereas you guys, some of you probably from California where the sun always shines. So there are important cultural differences. But I think in doing the clinical trial, you have to think about what the expectations are and try and equalize them between the different treatments and certainly minimize the hype. And of course, in ordinary practice, we like the placebo effect. We like people to have high expectations of positive results, and we work with that as therapists. But that is not what you can do in a clinical trial. So finally, you have to show fidelity in all phases of the support, because what the FDA in particular don't want is that the interaction between the therapist reflects the dose that the patient has received, be it or the placebo versus the active treatment. So that is an interaction that they don't want to see. And so they've even suggested that the integration phase in our trial should have a therapist who has not previously had any contact with the patient, as an example. They've suggested that, they haven't mandated it. And then finally, you have to blind the assessment, which we did. So why we offer psychological support and why I prefer to think of it and have argued in this paper that Elizabeth referred to as psychological support and not therapy is that the mindset and setting appear to matter going into the study. This preparation doesn't get people better without the drug. It's really designed to ensure safe passage. It gives people the courage, the confidence to jump into an experience that many of them may actually be inclined to resist. The drug effects themselves, when they're intense, are not really compatible with much interaction. I mean, I'll be guided by your comments on that, but that's my observation. And fidelity to the model needs to be demonstrable by consistent behavior by the therapist. So in a sense, we don't want in our trials the therapist to be highly reactive to what happens with the patient. We want them to maintain a consistency of approach, whether or not the patient is having an intense psychedelic experience or a not so intense psychedelic experience, or even no experience at all. And finally, an exploratory attitude to what actually works. In other words, not assuming that we know that the kind of psychotherapy required is already established, I think offers a future in which once we have the drugs available, we will be able to develop psychotherapies which are perhaps more specific to the needs of patients with individual diagnoses, perhaps more effective in increasing the durability of the response. So that's my piece on clinical trials. I'll hand over to Don to actually talk about his approach to how we actually train therapists, and we can talk whatever you like, really, but we can talk about how we see it when he's done that. So Don.
Great, thank you, Guy. You've outlined a lot of the challenges in training therapists to work in a clinical research setting with something as sort of powerful and significant as a psychedelic compound. The challenges around equipoise and blinding are sort of very real. And to be able to provide sort of consistent and reliable and safe support is really paramount for both the safety of participants and also our ability as a field to understand what is actually happening, what is beneficial about this process, and to make this kind of treatment feasible and available to everybody moving forward. And I think it's important to remember that, Guy already said this, but the model itself was not designed to be a standalone treatment. And that the way that we're approaching research really does provide this opportunity for us to demonstrate how this can be done safely and appropriately in a way that can be built on in the future by other kind of approaches and creating that foundation. And when you look at what do you want to get out of the psychological support, and maybe you can go ahead and pull up that first slide. Yeah, that's great. We want to be able to kind of answer the following questions when providing support for somebody. And that's, does this person have a sufficient understanding for what taking psilocybin might be like? Do they understand the basic kind of rationale for the type of support they're gonna receive during the experience? Have they been given the opportunity to practice the forms of support that are possible for them? Has the therapist explored like their intentions and expectations for what this experience might be like? And then also, has the therapist allowed the experience to unfold in a collaborative way, which honors autonomy and self-direction, which we'll get into in the next slide. So these things are paramount. Oh, go back. Don't go to this slide yet, Guy. Go back to the other one. But I want to kind of just spell out this sort of framework here, and that the support model itself, it consists of psychoeducation plus psychological support. And those things are delivered across these three phases of treatment that I think are familiar with those who are familiar with psychedelic treatments: preparation, administration, and integration. And then psychoeducation itself is really about this. Does the person understand what's going to happen? Have we investigated their expectations? Do they understand the role that you'll be working together? All of those things are really important for the participant, and are delivered both by the study team, by materials that they receive before they even meet with a therapist, and then discussed and checked out with the therapist during their preparation. Okay, now we can go to the next slide. And then we look at like the principles that form the foundation of the CPSM. There are three ones that are paramount. The first is sort of trust and psychological safety. You know, does this person trust the team that they're working with? Do they trust the therapist that they're working with? And almost more importantly, do they trust their own ability to engage with the potential for intense or challenging experiences that may arise? As far as skill sets that the participant needs to have is an understanding and the importance of engaging with the present moment. And I think this is really a core component of preparing for a psychedelic experience. When you look at the research, you know, there's emerging research that demonstrates that things like avoidance or pushing away or not willing to engage with difficult or challenging experiences can actually be harmful or detrimental to the therapeutic process. So we want to make sure that participants are prepared for that and have the skills and have had a chance to practice those skills in preparation. And so the support model and the therapist provides sort of two opportunities for direct practice and engagement with the present moment during preparation. The first one is through a style of using what we call curious questions, where they're asking people to reflect on the things that are happening to them, that they're experiencing in the moment, while they're discussing preparation or exploring their background or discussing in the depression studies, at least their history of depression and how depression has impacted their life. And then also through direct experiential practice. So providing an opportunity, if it's a fit for the participant, to practice breathing, to practice some really basic mindfulness techniques to keep them grounded and anchored through intense experiences that may arise during the administration. And then the last principle is almost more of like a process principle: self-direction and autonomy. And making sure that we reinforce participants' self-agency, the sense that they are in charge of their treatment, that they're in charge of the direction that they want to explore, and that they're in charge of kind of prioritizing what may be helpful for them from their perspective. This, I think, becomes particularly important when we look at integration. You know, psychedelics are thought to create a very open and sometimes suggestible state. And if therapists are leaning too far in and creating their own agendas or providing too much analysis or interpretation, that can be soaked in by the participant in ways that don't necessarily fit what is right for them and is true from their own experience or perspective. And really kind of being able to maintain that. And also, if you think about it, while the therapist can be there to support the participant during administration, they're not directly in the experience with them. That the participant really needs to have a sense of how to engage with what's happening internally while it's happening, and sometimes ways that the therapist simply will not be aware of for one reason or the other. So having this sense of like agency and autonomy, particularly during administration, is really critical in helping the participant engage with what's going on. And we can go to the next slide. Oh, interesting. Maybe click it again. There we go. This is a quote from, was taken from Jess Staples Keller when she was a therapist in phase 2B. She's now a current trainer. But I think it really highlights our approach quite well. And she said, "I never want a patient to think I was broken and I was fixed by Jess. I always want them to believe that they are the expert of their own experiences. They did the work and they have the power." And it's interesting to think about this quote, like just as a therapist, because I think as a therapist, and many people are working therapeutically in the audience, that you would say this almost about any form of treatment, that you don't want them to think it was you as the therapist that was in charge or sort of doing the work. And I think that's generally true. And I think it's very particularly true for the spirit of our support model and our approach, about kind of putting the participant as the expert of their own experience, and really the person should feel empowered in how they approach this process. You can go to the next slide. So I think it may be a little bit helpful to kind of talk about the therapist training that we do. So we really have put together, I think, a nice training experience that allows for this kind of consistent delivery, and has been challenging because we're training therapists across multiple sites in different regions of the world and sometimes in different languages in this clinical research setting. The therapist training itself, we have a really wonderful group of mentors and trainers who, most of which have previous experience in either psychedelic clinical trials or training in different modalities, which is a hard commodity to come by from people who are licensed professionals, although it's getting more and more common, thankfully. And we also take a stance that supports the professional growth of the therapists themselves. So, while we have our training set up to teach the skills and demonstrate the model, we also provide a lot of individualized feedback for the therapists that take our training program. And I think part of how we evaluate our therapists is their ability to model the values that we've set forth, being compassionate, open, culturally humble, curious, collaborative, and present. And that last one, I think, being essential to do this work well. And I think we have one more slide. And just sort of as an overview, we kind of, the training component itself, a self-paced online learning platform. That's probably 10 to 14 hours. There's a structured therapist manual that we provide. A live 3-day workshop that's full of role plays, experientials, group discussions, and also opportunities for individual feedback within that live 3-day workshop. So we'll do breakout rooms with role plays, and the trainers will be part of those breakout rooms, and sometimes providing really direct and customized feedback in real time to how the therapists are learning to deliver the model. There's obviously a direct clinical experience component. And then we also have a final assessment evaluation where each therapist meets individually with one of our mentors to do a role play review before they're sort of signed off to go work independently in the research trials. And all the therapists working in our trials receive monthly ongoing mentorship from one of our experienced mentors and trainers. And I think that we can pause there.
Pause there, Don.
Yeah.
Thank you so much, Don, for reviewing what goes into that training program. I mean, it's quite a rich experience, and I know from my experience both going through it and then also being a trainer providing it, that there's a lot that is taught in this and other training programs for clinical trials. And I think one of the key things that we think about when we're training clinicians for clinical trials is not just this standardization of making sure that everybody gets the same training, everybody knows what they're doing, but also knows what they should not be doing, and what the boundaries of the approach are. And so in the majority of cases, people in this role do have backgrounds as psychotherapists and mental health care providers. And also we're asking them to sort of contain themselves to the specific model that we want them to employ in this research study. And so I find that sometimes, there's a need for, there is a need for people to have that clinical experience and background. That's what gives people the capacity to be able to, for instance, create the level of rapport and relationship that they want, or that we want as clinical trial providers, in this short amount of time. Or maybe to be alert to and identify signs of trouble if somebody is struggling later in the trial, right? So that's where that clinical background comes in. But it's also very important that people know what is expected of them and how to kind of stay within the boundaries of the model. And so for those wondering why they may be asked to do so many hours of training if they're going to work on a clinical trial, they've already got a background as a psychotherapist. It is really to learn this specific kind of approach. But I really appreciate that. And one thing that I wanted to sort of ask a little bit more about is, there's a place in the paper where you're talking about the approach being thinking of it as part of what needs to happen for the data to be collected for regulatory approval. And that this doesn't mean that, this is exactly how it will happen in the case if and when there is a regulatory approval, but that this is part of how trials are designed in order to optimize getting the data that's needed to get to that point. And so, I think the comment was actually in comparison to another trial that I worked on, which was the NYU Psilocybin study, where we did have the integration of an evidence-based treatment, psychotherapeutic approach to working with psilocybin for alcohol use. And so there was this very clear therapeutic intervention. And alongside something that looked a little bit more like this, a psychological type of support designed to specifically work with the psychedelic experiences. And so I'm wondering, if either of you, Don or Guy, would tell us a little bit more about how you're thinking in terms of this design fitting in with what's needed for regulatory approval, and how that can and may very well look different from what could happen in a non-clinical trial environment post-approval, if that comes to pass.
Well, maybe I'll take it first, just because I'm kind of I have to meet the regulators, and that's less Don's problem. I mean, I think the key thing that they have laid out is that they would like to see minimal evidence for a role for an additional treatment component. They would like it to be a pure drug effect. Now, we have never really felt that you could deliver these treatments safely without the preparation that we just described, and that preparation is key to safety, but it's also key just to participation, if you like, that otherwise you would get dissociation, you would get people becoming very avoidant. And we simply didn't think, on the basis of previous evidence, that was feasible. So what we have done is, as I think we explained, is to prepare people, and then on the day to be fairly hands-off. So the day of administration of the drug, we have earphones to listen to a pre-recorded music choice. And we also have an eye shade, and we have basically a room which is pretty unstimulating. It's comfortable. It's designed to relax in. And so that environment is fairly consistent. What happens in integration, of course, is a little less obvious, but we hope that the therapists will simply be open-ended in the way they ask questions and just simply allow the patients to kind of follow their own course as a result of what's happened. Now, we think that that's a defensible argument for saying that's a minimal, safe psychological support that allows the expression of the drug effect. And we've seen the expression of the drug effect in a dose response curve in our phase 2 study, which is exactly what you'd expect a drug to do. So we think that that argument is convincing, and that's the argument we'll take to the FDA. Now, once the FDA, let's be clear, they do not regulate either psychotherapy or clinical practice. So once these drugs are available for clinical practice, I think the question of how exactly they get used, whether adding psychotherapy components to them, either before, but particularly after, when we think patients may be particularly receptive to behavioral change, that this is a very exciting opportunity for clinicians to innovate. And it's not for us to determine how they do that. Our job is to deliver the drug for the medical and clinical psychology and other professions to work with it. And that's our mission.
Right. Which in a way mirrors a lot of, we already have in the field. For instance, if someone is taking an SSRI, that doesn't dictate what kind of psychotherapeutic intervention their psychologist or psychotherapist might also employ alongside that. So I do see a parallel there. And I wanted to ask something else that I'm curious about. It also happens to appear in a question in the Q&A. So reminder, if you've got questions, please put them in the Q&A. I'm taking a look, which is that, when we think about what defines a psychotherapy and why we would say, well, psychological support really doesn't seem to be a psychotherapy, a full-blown psychotherapy. When I think about that, I think about a psychotherapy as something that has more of a full-fledged model for theoretical model for why the distress is occurring, and then a series of interventions or a series of things that the therapist does or tries to get the patient to engage in that stem from that theory and that are designed to alleviate that distress, right? So there's actions, but they're based on this theoretical model. And in this case, I don't really see it as being something, the psychological support model being something that's specific as attempting to intervene with the specific type of distress that's presenting, right? It's much more general, it's much more global. And I wonder if you for your comment on that, that's kind of how I see the difference here between psychological support and a psychotherapy intervention.
But that's the way I see it. But Don is better qualified to comment than me.
No, I think that's a really great point, because people tend to blur the lines between behaviors that are therapeutic and behaviors that are driven by a theoretical orientation. So you get into a lot of semantics about what is therapeutic, what is therapy, what is psychotherapy. And I think it's really helpful to make those distinctions in understanding and highlighting the fact that there's not a theoretical orientation per se is actually a really important piece. And it's also can be a challenge for therapists adopting this model, that have been practicing one way for 15 or 20 years to say, hey, lean back from that orientation, remain a sense of openness and collaboration, and set aside that part of the agenda while also, being a good therapist in your role as a support person here and providing that. So I think that's really critical. And I do think about it the same way. I also think about in the approach that we took to kind of modifying and updating the model, my stance has always sort of been like, what do we want the therapist to do? What are the skills that are going to be required to do this safely? And I'll worry a little bit later what label we call it or what bucket it fits in, because we could spend a whole hour just kind of talking about labels and semantics and all that sort of thing. And I think the primary goal is, how do we get participants to be able to engage with this safely in a way that's going to benefit them? And that's, to me, the primary focus.
And it's true too that certain psychotherapies do include things that may look very much like psychological support, But when they're practiced as a psychotherapy, they stem from this theoretical orientation that drives those actions as ways to try to help improve the presenting problem. Speaking very broadly, of course. And here, that's really not the case. But yeah, that and having the trainees take that step back is can be really challenging.
Maybe I could ask you, Elizabeth, because I debated Max Wolf recently in a UK-based podcast, and his argument is that the psychedelic experience is psychotherapy, and they put that into writing in the Lancet. He and Gerhard Gruder, who've obviously done work with TRD patients in Germany, and I'd be interested in what you think. I mean, do you want to say that the psychedelic experience is psychotherapy, or is that a statement you would believe or give credit to?
I mean, my gut instinct is no. It doesn't. For me, it doesn't set what I've just described. It doesn't really fit into that model of you've got a theoretical idea about what drives the suffering, and then it results in some action. Psychotherapy is something you deliver, usually to someone else. I think there can be a lot of ways in which it can work, right? There's like a lot of possible mechanisms in which ways that it can be helpful for someone. You've got subjective changes, you've got changes in perception, you may have changes in neuromodulation, or the way that your neurotransmitters are regulated afterward. There's just a physiological changes. I mean, there's so many different avenues that could potentially be helpful for someone. But the way that I just described a psychotherapy, I don't think it sort of fits into that mold. That said, I think it's a really important piece and can be very helpful, and maybe can be very helpful alongside a psychotherapy. It doesn't mean that model should be thrown out, just that for the purposes of testing and for collecting this kind of clinical data, this model does hold some weight, and it is something that we can use as a valid way to test what the differences are and what the actual results from the psychedelic are, without having to add that psychotherapy piece to it. Another thing I wanted to ask about, and this, Ingmar, you may have some thoughts about this as well. When I think about, the translation of research into practice and so, moving from the clinical trials environment into a clinical practice environment, you go from the evidence to the evidence-based practice, right? Practice that incorporates that evidence, but also makes it appropriate for the situation with the patient in front of you. One of the things that's really important in that is the acceptability of the treatment to the patient. And there are patients for whom the idea of coming in and having a number of long psychotherapy sessions really feels burdensome. It really feels like something they're not up for. And I think some of us as psychotherapists, we think psychotherapy is great. Like, why wouldn't everybody want to do that? But I've definitely talked to people for whom they haven't been helped by talk therapy before. Maybe they just don't feel comfortable really talking to someone and opening up about that way, or it doesn't feel like it really clicks for them. And so I wondered if you could speak a little bit to this as an access issue, that perhaps having this possibility of providing psychedelic treatment with psychedelic support and not requiring folks to engage in psychotherapy may actually make it palatable to some people for whom psychotherapy just isn't what they are willing to do.
What are your thoughts, Don?
I thought you were asking Ingmar there for a second about what the.
Either of you. I'm curious what either of you think, actually.
Can you just summarize the question for me?
How does this model, bear into the idea of there being an opportunity for people to access psychedelic treatment without needing to go through a full course of psychotherapy, keeping in mind that there are people for whom that won't be acceptable. They won't want to have to go through psychotherapy.
So I'm not sure I'm completely tracking. You mean like sort of in place of
Well, so
in a
if
clinical,
we only
like
tested,
discipline?
if we only tested and, you know, said, well, there's evidence for psychedelic assisted therapy where people have a full course of psychotherapy along with a psychedelic, we may wind up with, you know, a situation where we exclude folks later on down the line for whom they could benefit from the psychedelic, but they are not willing to or able to engage in a psychotherapy. So is that kind of part of the thinking here, to expand expand access and make this a possibility, a treatment that people can access even if they don't want to engage in psychotherapy?
Yeah, I mean, I think absolutely the goal is for accessibility and broad accessibility to as many people as possible that would benefit from the treatment. Whether they would benefit in addition to other treatments on top of that or in adjacent to, like that wouldn't be precluded, right? I think the more options that you have, the more treatment options and combinations of treatment options that people have, the better everyone's going to be. So you look at like access points, you look at like reimbursement, like all of those things matter. And so I don't know that there's going to be like a one size fits all model. And I expect that like people will do all sorts of interesting and creative and flexible things in the future, around psychedelics and how they combine them with other treatments or use them as standalone benefits. And I think that's part of what we've been demonstrating, and I think hoping to continue to demonstrate that if nothing else, this as a standalone intervention will have benefit for people. But it wouldn't necessarily to stop at that, if that's kind of what the question is.
I mean, just to pursue that access issue, Elizabeth, which you're absolutely right to bring up. I mean, one of the reasons for going through this whole rigmarole of regulatory approval is that it enables, access within the healthcare system to reimbursement. And that's our primary objective. And we're also taking steps to identify how the psychological support would be provided by getting from the American Medical Association a tracking code, which was announced actually earlier this year. And this was in working with Lycos Stroke Maps. And it means for both them and for us that come the day that we're in a position to offer these treatments, then at least the kind of the resources will be potentially there for reimbursement, both of the time that's required to support the patients and the drug. So that's very key to access, of course.
I could jump in for a second. I want to highlight something that Guy had mentioned, which is that the FDA, although it can create regulations around medicines and things like the REMS, it doesn't govern the practice of medicine. And that also applies to pharmaceutical companies. So I think what comes up for many clinicians when there's a debate about psychological support versus psychotherapy, I think perhaps one thing embedded in that is that whether clinicians will be able to practice the way that they want to practice, or be able to practice in a way in which they believe there's the greatest amount of support supporting their style of intervention. And just as a reminder that neither a pharmaceutical company nor the FDA will be determining how the clinician will be working. I think a question that arises for me around this is who's providing the support or the psychotherapy. I think one challenge is that, as Don, you had mentioned, and I experienced myself subjectively in trials, is that as a trained therapist, it is hard to sometimes hold back certain more active things that I would like to, interventions that I would like to be doing, because it's just sort of a muscle. And so there's that piece to it, but also there are certain, I believe, aspects to our training and also perhaps our traits as people who are attracted to psychotherapy that affect how we are with the participant or patient. And so the reason why I bring that up is back to this question of, well, who's going to be doing this work? I raise this as sort of a thing to think about, maybe a rhetorical question, not one that necessarily has to be answered. But it's sort of a factor that in many, if not all, of the psychedelic clinical trials across the board in the modern era, they're trained mental health professionals who are doing the work, whether it be, again, a full-on psychotherapy or support or monitoring.
Yeah, I think it's important to note in thinking of like who will do this work is to start with what are the skill sets required, and then understanding that the skill sets for prep and integration are not identical to the skill sets required for being present during administration. And so this is, I think, something we're all going to work towards and develop. But I think if we keep our eye on like what are the required skills and does this person have those required skills, like the rest of it will eventually sort of work itself out. But it's going to be interesting to see how this plays out. There's a couple of things that I'm kind of noticing in the questions in the chat that I wanted to circle back to, if that's okay.
Mm-hmm.
And one of them was around like the differences between like providing support in a research setting versus a clinical practice, and like what are the differences there. And one of the things I think that Guy touched on this earlier that I really want to circle back to is the importance of clinical equipoise in a research setting, and how it really kind of creates limits on what you would do that are different than, say, a clinical setting. So if you think about equipoise, I need to really be balanced in my presentation, regardless of like what may be happening. There's also this sense of you don't want to be priming beneficial effects too much by being too hopeful or being too expectant, or relaying in a lot of detail all the possibilities that could happen. And that's been very challenging for me as a clinician to adapt to that in the training aspect, and to understand how do you inform somebody about what to expect from a psychedelic experience without priming them too much about what are the things that could happen. Whereas in a clinical setting, it's like you can really lean into possibility and hope and change and the intensity of the experience in ways that become dangerous in a research setting. And I think are part of the reason why Guy said that doing double-blind placebo trials is kind of a brutal model, because, and this is one piece of that, is that it robs this thing that we would do as clinicians naturally that we know helps support change, and we just have to lean back from that. And I thought it was important to kind of recognize that, because it's an important distinction. And it's also an important component of the training of therapists that's different than what therapists are coming in with, and speaks to the need for the type of expensive training that we do, because this is a different kind of mindset that you don't get in your professional training. The second thing I wanted to know, some people were asking about whether sort of mindfulness and avoidance would be considered a theoretical orientation. And I think what happens for the support model and for the research trials is that what kind of takes the place for theoretical orientation per se is the mechanisms of the drug itself. So if you think about what can happen when you take psilocybin, positive, negative, otherwise, like those effects, the fact that it can generate intense emotional experiences, that it can generate intense like physiological or sensory difficulties, the skill of mindfulness, which could be used therapeutically in other ways, is a necessary skill to navigate those subjective experiences from a safety perspective. So in some sense, the drug mechanism becomes kind of the orientation for the support. And becomes kind of like the orientation. So it's not, we do a really wonderful job of, from a research perspective and science, and understanding and compartmentalizing, putting components and putting things into kind of different sections. But if you kind of just look big picture, this is a psychedelic experience does just the opposite. It kind of pools everything together. It's a connective type of experience. And it's very, very challenging. And I would say at some point, it is simply not possible to segment it in the way that we would love to And that's a good thing. That's part of what makes this a powerful experience in treatment for folks. But we're still going to do it anyway, because those are the best practices. And that's the way that we're going to be able to get the best understanding of what this treatment has to offer folks.
Thank you so much, John. Ingmar, go ahead.
Well, I was just going to say, I really appreciate that response. And I think we're also at time. So I think that's a really lovely comment to wrap up on. I'll hand it back to you, Elizabeth, to do so, but I just wanted to acknowledge that.
Yeah, really, really fascinating. And I'm sure our audience can understand how we could wind up talking about these things all day and often do in our work with these webinars, with our trainings, with our series, with the many drug development clinical trials trainings that we've run. It's just a really fascinating area to dig into. So I want to give a very, very warm thanks both to you, Guy and Don, for joining us today. Really thank you for bringing your expertise and your wisdom to this forum, and for sharing that with our students and giving them a glimpse of your thinking and your processes behind what goes into this kind of trial design and this kind of intervention design or treatment design. Thank you everybody who joined us. I know a few people probably had to drop off for another meeting. We're a few minutes over time. The recording will be available through the same classroom where you signed up. So if you want to check it out later, you're welcome to. Please come back for more. We've got a whole bunch of programs coming up this year. Stay tuned to our newsletter, because if you're really interested in getting trained in this kind of approach and methodology, either through a research trial or through just for your own practice, we really welcome you to do so. So I thank you again. Happy Valentine's Day. Hope everybody has a lovely rest of your day, rest of your afternoon, and we hope to see you around very soon.